Well, thank you very much, everyone, for your interest, and gives me great pleasure to introduce. Some of you will remember Dr. Ayoma Attygalle has taught several times on this programme previously, and has also taught on the Pathological Society Winter School, any of you who've managed to attend that. So Dr. Attygalle is consultant as a pathologist at the Royal Marsden. She originally trained in Sri Lanka and came to England as a kind of like on a fellowship, working with great Peter Isaacson, developing an interest in lymphoma. She is a world expert in follicular lymphoma, and particularly in the role of T follicular helper cells, and was instrumental in a lot of research which formulated their importance for some of the T-cell lymphomas. She's an excellent educator. She's been involved in teaching on programs that the Pathological Society has been involved in since 2016, so coming up for 10 years now. Talking today about reactive lymphoid lesions. These are, of course, at least as important as neoplastic lesions. They can be frequently misdiagnosed as such. One of the main problems we have in the UK, and what led to the development of our specialised lymphoma services, was the not infrequent confusion between reactive and lymphoid lesions outside specialist centres. So please treat this with just as much importance as learning about lymphomas. And so without further ado, and to not take our time, I will pass over to yourself, Ayoma. Thank you very much.
Thank you, Richard. Thank you. So these few cases are going to be on reactive lymphoid lesions. When you evaluate a case which is potentially reactive, it is important to try to get as much clinical information as possible with regards ethnicity, age, sex, site of involvement, in other words, distribution of the disease, is it localized, is there systemic involvement, and also is it an acute onset, is there been a chronic history, or are there systemic symptoms, and also if there's a travel history, pet history, all this may be relevant. And when you evaluate any lymph node, whether it be for reactive or neoplastic lymph node, or whether it be lymphoid tissue, you look to see whether the architecture is preserved or effaced. And if it is effaced, is it partially effaced or completely effaced? And if it's partially effaced, which compartment is affected? And also, if it's whatever the effacement, by what cellular infiltrate? So we'll crack on with the first case. So the first case is a 25-year-old female, and the history is jaundice and abnormal liver function tests, and a large fleshy groin node was found during exploration for a hernia. So this gives me the impression, although there is very limited clinical information, that the patient is unlikely to have been acutely unwell, but certainly there have been some abnormalities that have come to light, possibly as a result of testing, and when they thought they were exploring for a hernia, they came across this fleshy groin node. So what we have and what will be provided to you scanned is inguinal lymph node excision biopsy. The laterality was not provided. So one of the issues with these groin nodes is sometimes, it's not always that you get a nice intact groin node, because there's a lot of scarring which is known to occur at this site due to the repeated draining of various infections and so on from the leg. So as a result, it might not get a nice intact lymph node. And in fact, there's some chattering and scoring of this section as well. But what you are noticing is that the architecture of this node seems to be partially altered. At least I can see there's a reactive lymph node here with a mantle zone, but there seems to be an expansion of the paracortex of this node. And the scarring, as I said, is not something that is unusual, and this has caused some distortion to the node as well. In an area of the node like this is quite a fragmented node. You're seeing effacement of architecture. There seems to be some sort of follicular structure here, but otherwise it's markedly expanded paracortex, almost pushing the node to the periphery, the follicle to the periphery. So getting a closer look at this, there is an increase in high endothelial venules, and there is an infiltrate here, and what strikes the eye is there is a proliferation of large cells, but these large cells are not forming sheets. So these large cells, many of them have a central nucleolus, but they are sort of seen in clusters, and there seem to be slightly sort of medium-sized cells between them, some histiocytes, and also some small lymphocytes as well. There is a very occasional eosinophil, if at all, but otherwise no eosinophils to speak of. Now, here there's a single eosinophil that you're seeing, but otherwise no eosinophils. And again, what you notice now, this is slightly higher power, that there is this infiltrate of large cells. However, the large cells are not a monomorphic population of a sheet of uniform-looking large cells, but there's a variation. There are these large cells with central nucleoli and some with just more than one. And then there are some slightly smaller cells. There are also cells which look like sort of slightly larger, like large plasma cells. There are also mature plasma cells. So there seems to be a spectrum of size, and also in a cell type, you're having plasma cells at one end of the spectrum, and you're seeing some large immunoblast-like cells with central cherry red nucleoli in some of these. So it's not a uniform, it's somewhat, although there are different cell types like neutrophils, eosinophils, and so on, this infiltrate itself is not monomorphous. There is a certain amount of polymorphousness to this infiltrate, and that is a very important feature to keep in mind. And here again, this is another section of the same node, and again you can see the hydrothelial venules, and again you're seeing these large cells, and it's quite prominent, but they're not present in sheets. And when you look at the CD20, if you look at the inset in the above left, here top left, you can see that you're seeing follicular structures, and here there's the FDC meshworks on the CD21 pushed somewhat to the periphery, and there's an expanded paracortex within which there are this infiltrate of largish B cells. Now these B cells are seen in clusters, just like we appreciated on morphology, but also you're seeing some cells that are showing strong CD20 and others that are sort of showing weaker CD20, which suggests that these cells, the weaker CD20 is often because they're moving towards the plasma cell end of the spectrum. Here again is another CD20, a closer look. You can see the clusters of large cells and some sort of cells of medium size. And this is, I've just put an IgD to show you that the mantle zone cells in these follicles are positive for IgD. There are far more CD79A positive cells than there are CD20 positive cells. And again, the large cells are positive for CD79A, but also there are cells which are plasmacytoid, and also the mature plasma cells are also positive for CD79A. There are quite a number of T cells in the background on CD3, and that accounts for also the small T cells, the small lymphocytes that you saw on morphology. But in addition to small cells, there's a spectrum of cell size here. So you're also seeing some cells that are somewhat large. Now, one of the things when you evaluate atypia in T cells, if it's markedly atypical and anaplastic, you will be confident about calling it lymphoma. When you see this kind of atypia, there's a huge overlap between what you expect in reactive atypia in T cells and neoplastic conditions. So be very careful about calling this degree of atypia outright neoplastic without proper evidence. And remember, don't ever forget that the age of the patient is 25 years. So this kind of, if you see T-cell lymphomas at this age, it would be likely to be anaplastic large cell lymphoma, which are large anaplastic looking cells. Then those ones are often the positive anaplastic large cell lymphoma at that age. So this doesn't look anything like it. So there's a spectrum of the changes in the T cells as well. You have some few large cells, but most are medium and small. CD30 is highlighting large cells, but also cells of medium size as well. So there's a spectrum. Remember, activated lymphoid cells, whether they're T cells or B cells, express CD30. So CD30 is not just a marker of Hodgkin-Reed-Sternberg-like cells or Hodgkin-Reed-Sternberg cells or anaplastic large cell lymphoma. Okay. So the T cells are there are CD4 positive T cells, and also remember histiocytes will be CD4 positive, but also CD8. And CD8 is highlighting some of these atypical cells. So remember, when there are viral infections and so on, you can get a cytotoxic T cell response to the virus, and also if there is a lymphoid proliferation like B cells, you can have a response to the B cells that are infected by a virus. You can have a cytotoxic T cell response. So now the differential diagnosis in this case, the main one, if it looks like this, the main differential diagnosis really is this a large B cell lymphoma? And what are the features that are against this? There's partial preservation of architecture. Now, partial preservation of architecture alone is not sufficient. So you have this expanded paracortex, but what is important here is keeping the age of the patient in mind. These large cells are mostly clustered and intimately admixed with plasmacytoid and plasma cells, and they don't form sheets of large cells. If you see a monomorphic sheet of large cells in an interfollicular distribution, of course it could be large B-cell lymphoma, but this is not what you're seeing here. And also, in this case, this patient could have been somewhat close to being asymptomatic. So that is something also to keep in mind. If it's a large cell lymphoma, it's oftentimes that the patient is unwell. And if this presentation also is just very acute, then also you have to think of the possibility of an infective etiology. Remember, this is a young patient, and if you can, it's not always forthcoming. And I can tell you, I think this is the gripe of pathologists worldwide, that we don't get enough clinical information from our clinicians. Now, so if you look, I know these stains are not universally available, but they are available here. So I did them just to show you that these cells. You can see there is a lot of immunoglobulin in these cells, and that is why it has this plasmacytoid appearance. So these immunoblasts also have quite sufficient immunoglobulin, so that they stain quite well with the kappa and the lambda. Sometimes it's difficult to get the kappa and lambda stains to work on small B cells, but cells like this, where there's plenty of immunoglobulin, it's very easy to stain them. So, you get a good outcome. So you're seeing that there's both kappa staining cells and others that are staining lambda. So this is polytypic for light chain. So here, the clue, you don't have to think very hard. This is obviously a polyclonal in proliferation. So in other words, a reactive infiltrate. And so this is the EBR, which is the EBV-encoded RNA. This is the in situ hybridization, and you're seeing the large number of EBV positive cells. So I'd like to have had a Q&A to ask you whether this is a poll question, to ask you what you think of this. But I think all of you must have worked out the diagnosis by now, and that is infectious mononucleosis. Now, infectious mononucleosis is caused by EBV. In the West particularly, it occurs in adolescents and young adults. But in the West, older adults may be affected less commonly. Now, in the country that I come from, which is Sri Lanka, and I'm sure in most of sub-Saharan Africa, the EBV infection occurs at a much earlier age. And you will have some patients who are asymptomatic, but you might have others that have symptoms. So I think it is important anyway to keep in mind the world is getting smaller, and I think we need to be aware of this because of the pitfall of misdiagnosing this as malignant. And I'll tell you a little bit about that in a minute. So often the presentation is pharyngitis or with the nasopharyngeal blockade, the cervical lymphadenopathy, splenomegaly, and with or without a skin rash. And generally the clinical symptoms are of a short duration, and the peripheral blood will show reactive, atypical looking lymphoid cells. You can do a monospot test, will be positive, but if you don't have access to EBR, LMP1 is a stain that can be used, but it doesn't pick up all the cases, so that is why that's a problem. But if you have access to EBV serology, the EBV IgM will be raised. In early cases, there's follicular hyperplasia, monocytoid B-cell hyperplasia, and clusters of epithelioid cells. So overall, there can be a resemblance to toxoplasma lymphadenitis. However, it is the later stage where paracortical changes predominate, and this is often when these cases are biopsied. So the lymph node or tonsillar architecture is typically not entirely effaced. The paracortex in a lymph node is markedly, and the interfollicular compartment in the tonsillar mucus-associated lymphoid tissue can be markedly expanded. But residual lymph node architecture may not be appreciated. I mean, in this biopsy that we had also, you had to look quite hard to find in some of those fragments to find the residual follicles. But on core biopsy, certainly it may not be. You might just see the expanded paracortex only. It is a polymorphous infiltrate, and there are lots of immunoblasts which can form small sheets or clusters, and some of these immunoblasts may resemble Hodgkin-Reed-Sternberg-like cells. Here on the left, you're having a cell which looks somewhat with a large nucleolus looking like a mononuclear Hodgkin cell, and this one looks like a textbook Reed-Sternberg cell. So, you have to be a bit careful about overdiagnosing these. But you will have the plasma cells and the plasmacytoid cells. If you look at this on the right-hand side, there's a full spectrum of changes of, starting from the plasma cell, then a largish plasma cell, etc. And eosinophils are not usually seen. Now, in a groin node, one of the issues you have is that there can be a pre-existing inflammatory conditions such as dermatopathic change, which can have eosinophils. So that may be from the pre-existing condition rather than this. So seeing an occasional eosinophil, I wouldn't change my diagnosis. Sinuses may have monocytoid B cell aggregates, small lymphocytes, and immunoblasts, and there's a prominent of high endothelial venules, like in the case that we have. So on immunohistochemistry, and the in situ is only for really useful for you can do Kappa and lambda in situ as well, but this is for the EBV. So it's a mixture of T cells and B cells. The B cell immunoblasts can be prominent and may form clusters and sheets. Generally, like you saw, the CD79A exceeds the CD20 because of the plasmacytic and plasmacytoid cells. The if you see Hodgkin-Reed-Sternberg-like cells, they're CD30 positive because any activated lymphoid cell will be CD30 positive, but there's usually CD15 negative. And importantly, the EBV is positive cells are seen in varying size in the paracortex. This actually is in the red pulp of the spleen. And EBV and LMP1 may be positive, but as I said, it's better if you have access to the in situ hybridization. The T cells, the CD8 exceeds CD4 because this is a viral. This is the cytotoxic T cells are used to fight this virus, which is in the lytic cycle. So now I'll give you a few more clinical scenarios of infectious mononucleosis. So this was a 30-year-old male with a spontaneous splenic rupture. Here again, you're seeing the white pulp, but the red pulp looks expanded and very, very busy with and doesn't look normal at all. And if you keep going higher, you will see that this is the polymorphousness that I'm trying to emphasize. You're seeing mature plasma cells, then you're seeing a large cell which looks like a large plasma cell, almost like an atypical looking plasma cell, and there are some large sort of cells here which could be immunoblasts. Many of these could also be activated T cells, remember. And here again, you're seeing this spectrum of change. It's not a monotonous infiltrate of large cells. So this is CD20 positive. Most cells are positive for 79A, but this is an example where there are a lot of T cells, the CD8 positive T cells in this spleen. They're CD30 positive, the large cells, proliferation is high, and you can see that the EBV is positive in cells of varying size. This is another example of a 6-year-old female with acute onset of complete nasal blockage due to a large mass filling the nasopharynx. It was partly necrotic, and the question was, is it acute infection or is this tumor? And this is the nasal biopsy. So you're seeing a lot of ulcer slough here. And just beneath this ulcer slough, if you look at this area, this is what it looks like. So you can see the slough here, but here you can see that Reed-Sternberg cell that I showed you. We'll see it in higher power in a minute. And you're seeing again this sort of spectrum of cell size. They're sort of a similar population, but of varying size. They are not different cell types. And you can see here, this is this Reed-Sternberg cell and other large cells. This one has a very large nucleolus. And in an area like this, deeper, there are still similar cells. It's just that you're not seeing the ulcer slough and maybe fewer histiocytes, so it's less pink. But here you're seeing this clock phase chromatin of the mature plasma cells, and you're seeing the spectrum of larger cells as well as there'll be background, a lot of T cells as well here. So here again, this is in the area where there's the ulcer slough, you're seeing the EBV positive cells of varying size. So in addition to large B-cell lymphoma as a differential, the other differential in cases of infectious mononucleosis is classic Hodgkin lymphoma. So I mean, this is a bigger problem than you realize, especially if you get co-biopsies. And I'll tell you a few clinical examples I'll just talk you through a few clinical examples in a minute. So one of the important things is if you see a lot of eosinophils, which you tend to get in classic Hodgkin lymphoma, it is unlikely to be IM. And PG15 is usually negative in the large cells. EBV is positive in not only in the Hodgkin-Reed-Sternberg-like cells, but in IM it's seen in a range of cell sizes. And also, if you diagnose Hodgkin lymphoma, remember that Hodgkin lymphoma, the lymphadenopathy is contiguous lymphadenopathy. So you wouldn't get, say, for instance, peripheral lymph nodes without the central lymph nodes. So central lymphadenopathy is really important. And I mean, if there's a mediastinal mass, it will be and you have cervical lymph nodes, it's a continuous chain of nodes. And even if you have in the abdomen, it will be a chain and it will be centrally located, these nodes. If you have a groin node, that is usually part of the chain of nodes rather than just a groin node and the next set of nodes you'll see in the axilla. It doesn't work like that. It's not just peripheral lymphadenopathy. You have to see this central lymphadenopathy. So that's something if you're unsure, always correlate with the clinician about the disease distribution. There are other conditions where these come into the differential. Chronic active EBV infection, it's a much more protracted course, and the IgG levels will be high as opposed to the IgM. The immunosuppression-related lymphoproliferative disorders like post-transplant lymphoproliferative disorders, and in older patients, because of senescence related to old age, but also in immunosuppressed patients, if they're superficial ulcers, the EBV positive mucocutaneous ulcer. There are also large EBV positive large B cell proliferations in nodal T follicular helper cell lymphomas. So this is also something to keep in mind in older patients. But I think it's very important in these situations, when you see a young patient, this patient is 25 years old, not to misdiagnose this as lymphoma. And that is actually the key message here. In fact, Dr. Elaine Jaffe, who's a world-renowned hematopathologist, in her book, one of the things as a registrar I read was that one of the biggest complications of infectious mononucleosis is biopsy and misdiagnosis due to biopsy. So that is, I think, something that we have to keep in mind. It's often about just being alert and thinking about it. We've had cases that were initially misdiagnosed. These are like tonsillar masses, just because it was a young patient, but patient was intubated and patient was very sick. In infectious mononucleosis, patients can be sick, but they get well very soon, spontaneously. So there was another patient who was in pregnancy who had infectious mononucleosis, again misdiagnosis as a large B-cell lymphoma. So these misdiagnoses do happen. So it's very important to keep in mind and to be aware, that's all. And then if you think about it, you can do the necessary investigations. If you have access to EBER, that's good. Otherwise, ask the clinician you can do an LMP1 if you have access to that. And if that's negative, ask the clinician to do the EBV serology. So points to remember is lymphadenopathy and enlarged tonsils in adolescents and young adults. Think about it. Children mostly present with nasal congestion, and you have to have a high index of suspicion, get a good clinical history in order to prevent misdiagnosis. Richard, do you want me to take any questions on this before I continue with the next case, or shall I just continue?
I think, yeah, just open it to the audience if there's any questions. I think
Yes,
we've got time to do that.
Yeah, I think we have a little time, So
Are there any questions from the audience for Dr. Attygalle at this stage, please? Because infectious mononucleosis is often mistaken for other diseases. Any hands up?
No questions?
No? Okay.
Anything on the chat? Shall I just check the chat?
Yeah.
No, nothing.
Okay. Proceed then.
Okay,
Yeah,
that's fine.
Thank you.
So next case is a 50-year-old Somalian female. Right axillary lymph node enlargement, no other sites involved clinically. Biopsy, co-biopsy from the right axillary lymph node. So this is the core. It's a good core. And you can see the right-hand side of the core looks very pink, and this is not because the hematoxylin hasn't run to the end of the slide, end of the section. It's because this is as an area of necrosis. And on the left-hand side, you can see the viable part of the lymph node with reactive follicles and patent sinuses. There's something going on here also in the paracortex, in the superficial paracortex here, next in between these follicles. But let's just look at these areas one by one. So this is the capsule, and there seems to be some inflammation, and you can't really appreciate the marginal sinus very clearly. It seems to be fibrosed here, but there seems to be some dermatopathic type change in the paracortex here. You're seeing the pigment here as well. But if you look closer here, even in this area, there seems to be some apoptosis and a few macrophages. But let's just move on to the area that was of great concern to us, and that is this necrotic area. And the reason why it's so pink is, now you can see why, because there's a lot of cytoplasm, pink cytoplasm in these cells. And what is striking here is that there is apoptotic debris, but there are no neutrophils. And there's quite a lot of what looks like histiocytes. Some of them have this elongated nuclei, and some have this sort of almost C-shape to the nuclei. There are other histiocytes as well, and there are lymphocytes certainly, and there's possibly other cell populations as well, which we'll see in a minute. You move around the area of necrosis, and you come across some foamy histiocytes as well. And in the areas of foamy histiocytes, you can see that there is not that much apoptosis. This is the area that the lymph node was viable, and you can see there are reactive follicles and patent sinuses. So this part of the node is unaffected. So on the CD20, you can see that, yes, the CD20 is confined to the B cell areas, but there's no B cells in the necrotic area, whereas you can see T cells in the necrotic area. So again, this is a little better view of CD20, and you can see that there is really no B cells in this area, and the B cells are confined to the reactive follicles with just a little spillage into the perifollicular area, which is actually allowed. And CD21 is highlighting these FDC meshworks of the follicles. What about the T cells in the necrotic area? So again, you're seeing a degree of atypia, a range of T cells. Some of them are small, some of them are medium sized, some of them are really very irregular nuclei. So as I pointed out earlier, the real issue with, and this is the problem in the diagnosis of T cell lymphomas, that there is this overlap between the changes that is acceptable in reactive conditions and those that are neoplastic. And to overdiagnose T cell lymphoma is actually as bad, or I do think in a way maybe worse than than missing it. So, the patients will be unnecessarily treated, and, there's a lot of morbidity associated with that. So I think it would be, it's very important to get the diagnosis right. But anyway, you recognize that there is some degree of atypia, and this could be reactive, we don't know. And the T cells, there are few CD4 positive T cells, but there are quite a number of CD8 positive T cells, including the atypical T cells are CD8 positive. But we've now seen, you remember you saw the atypical CD8 cells in the infectious mononucleus. It didn't make it neoplastic. So that is something you should keep in mind, that degree of atypia is acceptable. But what is really unusual is that there is myeloperoxidase expression. Remember, there were no neutrophils. So there were no we didn't seem to be any sort of myeloid precursors or anything like that. So what is expressing the myeloperoxidase, or which cell population is expressing this myeloperoxidase? It happens to be the histiocytes within this lesion. So you notice that there are some cells here which we don't quite know what they are. So let's look at that a little closer. That these are these cells which it's difficult to work out. Some of them look a little plasmacytoid, but it's sometimes difficult to identify, especially when they're in a mixture of other cell types. But CD123 is a marker of these cells, and you can see these are plasmacytoid dendritic cells. So there are quite a few of these as well. Now, in addition to the apoptotic debris that you can see here and this mixed cell population, in this particular case, there are a few plasma cells. And this is something I would like you to just keep in your mind, and we'll discuss this aspect of it a little later. So the diagnosis in this case is histiocytic necrotizing lymphadenitis, or Kikuchi-Fujimoto disease, or lupus lymphadenitis. Now, I'm going to show you one extra case very quickly before we discuss this. Now, this one is in a 26-year-old male, not a female, a 26-year-old male with cervical lymphadenopathy. And in this particular example, again, it's an excision biopsy. Most of the lymph node you can see is nice and well, the architecture is preserved, but there's partial effacement because of this nodular area, which we have started in the paracortex, but it's mass forming here. And if you look at this again there's apoptosis, which is very karyorectic debris, but there are no neutrophils. And again, you're seeing this mixture of cell types, including the C-shaped histiocytes, and in this particular example, quite a lot of histiocytes. Now, in Kikuchi-Fujimoto disease, you see these paracortical clusters of plasmacytoid dendritic cells, presenting histiocytes, and karyorectic debris, but no neutrophils. This is histologically indistinguishable from lupus lymphadenitis, and all cases, such cases, should undergo serological testing to exclude SLE. Features that favor SLE are extensive necrosis, hematoxylin bodies, plasma cells, which we saw in this case, if you remember, and even occasional neutrophils. Now, please don't send this for clonality analysis, because one may encounter transient reactive clonal or oligoclonal proliferation. So this will give rise to clonal or oligoclonal patterns of T-cell receptor gene rearrangement by PCR, which, although reactive, will help. If you think those T-cells were atypical, you've sent it for clonality, you've got a small clone, and you think this is lymphoma, this is just helping you to confirm a misdiagnosis. And the reason I'm pointing this out is because if you don't think about it, we had a case here where the patient had histiocytic necrotizing lymphadenitis, was diagnosed as a T-cell lymphoma, and was then treated for a T-cell lymphoma. It came to our institution for transplant. And in the workup for that, when we reviewed the biopsy, it was Kikuchi disease or histiocytic necrotizing lymphadenitis. So it's really important not to, and there was one instance where I went for a meeting and I met a pathologist who said, I had a case which was necrotizing, it was a T-cell lymphoma. I sent it to Dr. Jaffe, who's sort of a world-renowned hematopathologist, and she called it a lymphoma, she called it reactive, she called it Kikuchi disease. And I said, yes, because that's likely to be what it was, you see. So I think it's really important not to underestimate, the difficulties in diagnosis of these cases sometimes. So this is predominantly in young adults and especially women of Asian descent. The cervical lymphadenopathy, and you can have systemic symptoms as well. These patients have fever, but most cases respond and resolve spontaneously. There are 3 stages. So there's a proliferative stage. Yeah, I'm showing you an example of that in this slide, where you see a mixture of cell types, and sometimes this can be very confusing. But if you look hard enough, you will see this karyorectic debris, even though it's minor, and that can be a clue. And all you need to do is do a myeloperoxidase here, and you will see this lighting up, and that will give you the clue. And then you have the necrotizing phase, which is when the biopsies are usually performed. And then you have the xanthomatous phase, when it's all getting, this is the phase that is moving towards resolution. And in our case, you're seeing there's proliferative phase moving towards the xanthomatous phase, where you're seeing some foamy histiocytes as well. In the xanthomatous phase, the problem is that you see a lot of foamy histiocytes, and because they're young, you might misdiagnose it as a storage disease. So our case would be a histiocytic necrotizing lymphadenitis, should be either Kikuchi-Fujimoto disease or lupus lymphadenitis. And this is proliferative to very early xanthomatous stage, and you should exclude SLE by serology. And I'll show you a few examples of cases. This is a patient, 15-year-old female with SLE, with fever and night sweats, and this is a cervical lymph node. So the degree of necrosis can be this significant. So you can see this is very necrotic, but you still see this karyorectic debris. And if you look hard enough, you'll see the C-shaped histiocytes. I apologize for this. I have put my phone on Do Not Disturb, but so C-shaped histiocytes and karyorectic debris. And then this is a 38-year-old female, mesenteric node. Again, there's so much necrosis, but what is very interesting here is, I wonder whether any of you know what this is. These are hematoxylin bodies, and this is a really good clue towards SLE. Okay, and here I think I can see some plasma cells here as well. You remember I told you that you can see plasma cells also as a feature of this. So the pitfall also, as I said, the T cells can be atypical and sometimes markedly atypical. So this is a 21-year-old female, cervical lymph node, query lymphoma. So this is, you can see this is mass forming and there's a large area of necrosis. And you're seeing again karyoretic debris, no neutrophils, and again this sort of mixture of cell types. But when you do and here also the histiocytes that I was telling you about in some of the areas, if you look around. But what happens sometimes is when you see atypical cells and you do immunostains, now this is CD3, and these T cells look really atypical. And here you're seeing one which, I don't know, it has a funny shape as well, and it's mitotically active as well. And this is a CD8. And this is highlighting the ATPI in the T cells. So when this case came to me, the pathologist who sent it to me was querying lymphoma in this 21-year-old. And my registrar at the time looked at it and said, gosh, this has to be lymphoma. So I think you have to really be careful about overdiagnosing. Take the age into consideration. Look to see what type of lymphoma could it be. You know, my former boss used to say, if you can't work out what type of lymphoma it is, and, you know, it might not be lymphoma. So I think be really careful and take the whole picture. Just don't look at one immunostain and go down that route. The proliferation index is also high, which can also add to confusion. This is myeloperoxidase positive, and that is really useful. So when I was sitting my FRC Path Part 2, in the long case, there was a case of Kikuchi of necrotizing histiocytic lymphadenitis. And in the long case, as you may know, they give you immunostains as well. So there was a myeloperoxidase, there were the T cell markers as well. So some of the candidates had called this myeloid sarcoma because of the myeloperoxidase, and others had called it peripheral T cell lymphoma because of the atypical T cells. So I think most of you are probably aware of this condition and the immunostains and the value of the immunostains, really. So here, myeloperoxidase is actually very useful. So the immunostains are CD3, CD20, CD4 and 8, and myeloperoxidase, CD1, 2, 3, if you have access to it. In these cases, you may also just, if you have access to EBA, in situ hybridization, you can just put it out there because, you know, you can get necrosis associated with EBV proliferations. But so EBV will be negative here. Okay, so the differential diagnosis of necrosis in lymph nodes, herpes simplex lymphadenitis can cause necrosis, but it is associated with neutrophils, and if you look hard, you'll see the viral inclusions. Infectious mononucleases, not the examples that we saw, can also give rise to geographic necrosis, but the infiltrate, if you remember, was polymorphous, and there are B cells that are EBV positive. And you can also, if you don't have access to EBA, you can do the EBV serology. So the if you take lymphomas, you know, we know that extranodal NKT cell lymphoma can have this often characterized by geographic areas of necrosis because of angio invasion and angio necrosis. So, but EBV positive nodal T and NK cell lymphoma, necrosis is only very occasionally a feature. So that is something quite useful because this is involving lymph nodes. And also, you know, you have to take the clinical into consideration as well, okay? And these are EBV positive. So this is, and of course, large B-cell lymphomas can have necrosis, but they will be positive for EBV, for B-cell markers, okay? So any questions on this before I go on to the next case? Richard, any questions you think?
I think we'll carry on
and
take questions at the end. I've got a few comments as well. Thank you.
Okay, fine. Yeah. So then we'll move on to the next one, which is the third case. It's a 23-year-old male. This is a lump in the left neck, and this is an excision biopsy of this lump, which happened to be a left cervical lymph node. So this lymph node, there is, what you see immediately is that there's an alteration to the architecture. So one of the things, in fact, when I showed the slide to my registrar, the first thing she said was, I can't see any sinuses here. So that is something that, so there are no sinuses here. Yes, the sinuses are either compressed or in some way not visible anyway. And this follicles, they seem to be abnormal, and there seem to be quite a lot of them. So there's a high density of these follicular structures. So there's an alteration to the architecture, although I wouldn't say the architecture is effaced. And this is the towards the capsule of the node. So you're seeing these abnormal looking follicles extending throughout the thickness of this node. And looking closer at these, what is very striking is these follicles have an expanded mantle zone with nice concentric layering of the mantle zones, and there is regression of the germinal centers. Some of these follicles can have a vessel, and you can see here, there's a vessel entering the follicle at right angles. And in the interfollicular compartment, yes, you can't see the sinuses anywhere, but what you are seeing is there's fibrosis, there's an increase in the venules here, the endothelial venules, and there is an infiltrate of small lymphocytes. So clearly this is not a normal lymph node. And then if some of these, you can see this as germinal centers, some with regressive features, but this follicle has one mantle zone, but it has two separate germinal centers, okay? And then more of the same, you're seeing sclerosis in the interfollicular compartment. And again, there is this regressed follicular structure. A vessel entering the follicle. Another vessel, somewhat sclerosed, entering the follicle. And these follicles we refer to as lollipop follicles. A lot of sclerosis in some of the areas of this node. And the interfollicular compartment, you can see here that there is this prominent increase in vascularity. And there is hyalinization of these vessels, so leading to fibrosis. And the lymphocytes here are small lymphocytes. So what did the sinuses are not seen? Follicles are regressive follicles. They're expanded mantles with concentric layering and onion skinning. There's penetrating vessels at right angles into the follicle or what we call the lollipop follicle. The feature that is actually most specific or the most useful really is if you identify these more than one germinal center sharing a single mantle, in other words, twinning of germinal centers towards the diagnosis that in this case. The interfollicular area is an increase in endothelial venules, there's fibrosis and small lymphocytes. So if I look at, I've highlighted this area in this rectangle here on the left and on the HNE, and on the right, this is the CD21 in that area, and you can see this is a sort of expanded follicular structure with multiple germinal centers, regressed germinal centers. So not just twinning, but this is quadrupling, yes. And here again, this is on CD23, these are both FDC markers, and here this is another area where again you're seeing twinning of the follicles, for the germinal centers within this sharing a mantle zone. CD20, you see just red confined to these abnormal follicles. They are IgD positive mantle zone cells, and the T cells are in the interfollicular compartment. So those T cells that you saw in the hypervascular interfollicular areas are T cells. The regressed follicular structures are reactive. In other words, they're not neoplastic. So they are BCL2 negative and CD10 positive. And what is conspicuously absent in this lymph node is plasma cells. So you're not seeing, there's no increase in plasma cells. Anyway, there are no plasma cells to see. So this diagnosis is quite straightforward. This is a unicentric Castleman disease, hyaline vascular subtype. So what is the differential diagnosis for regressed follicles? Because just seeing regressed follicles are not specific to hyaline vascular Castleman disease. So one of the things I've noticed is that sometimes we pathologists, we tend to say there are Castleman-like features. Now that is a real, that is not acceptable really. It's either hyaline vascular Castleman disease or it isn't, okay? So when you say Castleman-like features, is it just that these have regressed follicles, you see? So you have to say what you mean rather than, because you can confuse the clinician, you see? So regressed follicles can be seen as a non-specific reactive feature, can be seen late stage of HIV, it can be seen related to IgG4 related disease, plasma cell variant of Castleman disease, there are hyperplastic and regressed follicular structures. Nodal T follicular helper cell lymphoma of the angiomoblastic type, the pattern 2 as we describe this when there are regressed follicles. And also small follicles of follicular lymphoma, when there's hyalinization, can be a problem in differentiating from a regressed follicular structure. Also, in a mantle zone pattern of mantle cell lymphoma, you see a broad mantle zone and a small germinal center, which can also lead to confusion. So unicentric Castleman disease, the fifth edition of the WHO, by the way, includes reactive lymphoma-like conditions as well. So this is from the WHO Blue Book. So hyaline vascular subtype accounts for around 80%. So it's not all the cases of unicentric Castleman disease. So you do get mixed and plasmacytic subtypes, which are just one single lymph node or a lymph node station. So hyaline vascular unicentric Castleman disease is a localized form of Castleman disease. It may affect any age, but commonly in the fourth decade. It's a localized mass. It's usually a single node. It can occasionally be one group of lymph nodes. In other words, one lymph node station, in other words. Mediastinal and cervical lymph nodes are most commonly affected. Usually they are asymptomatic and they're found and when they do incidental imaging for something else, or in the mediastinum particularly. It's not related to HIV in contrast with the plasma cell variant, and the treatment is just resection. Rarely patients can develop FDC sarcoma, and this you might see hyaline vascular Castleman disease adjacent to the sarcoma, and you might see FDC dysplasia within the hyaline vascular Castleman disease. So in other words, this FDC sarcoma is arisen from the hyaline vascular Castleman disease, a very rare complication. There's evidence now to suggest that this is a clonal proliferation or neoplasm derived from stromal cells, very likely FDCs. And some studies have demonstrated a clonal karyotype and gene mutations in PDG, F beta has been shown in 17% in this study from 2019. But monoclonality appears to increase and correlate with the monoclonality correlates with the size of the lesion. And occasional cases can also show FDC dysplasia. So that is unicentric Castleman disease. But I'm also going to quickly show you a case of HHV8 associated Castleman disease. So this was a 44-year-old Ghanaian male, fever, abdominal pain, massive lymphadenopathy, and widespread lymphadenopathy. Massive splenomegaly and widespread lymphadenopathy. So you can see this is systemic. There are systemic symptoms and the patient is unwell. Pancytopenia, polyclonal gamma globulinemia, and this was an axillary lymph node biopsy. I'm just going to show you a few slides only and just focus on this follicular structure here. You can see it's regressed, the germinal center here. Follicle center is regressed follicle. And there's something going on in this mantle zone where there are some largish cells here. There's a large cell, and it seems to be also some encroaching on the germinal center. So let's have a look at this a little closer. And in the interfollicular compartment, you're just seeing a sheet of mature plasma cells with this clock face chromatin. So if you look at the follicle, the IgD highlights the mantle zone cells, and HHV8, this is LANA antibody, is highlighting your cells here, which are HHV8 positive. These are plasmablasts. They are called plasmablasts purely because they have a lot of immunoglobulin, and they are IgM expressing. They are not CD138 positive. What is positive for CD138 is the interfollicular plasma cells that we saw. And the interfollicular plasma cells express IgG, and they're negative for the IgM. What is interesting is that this HHV8 positive plasmablasts are lambda expressing, and the virus seems to be hone in on the lambda and preferentially infect the lambda. So it's lambda light chain restricted and or monotypic for lambda, but this is polyclonal. So this is a very unusual example of a situation where you have, we tend to use a monotypic expression of light chains as a surrogate for monoclonality, but this is an exception to that rule. The interfollicular plasma cells, on the other hand, are reactive anyway, and they are also reactive, but they are polytypic for light chains. So the HHV8 positive Castleman disease can go on to develop a lymphoma, but I'm not going into that now. So multicentric plasma, this plasma cell variant of Castleman disease can be HHV8 positive, and these or KSHV positive. They may be associated with HIV, and they are associated with IL-6 related symptoms. And the HHV8 positive plasmablasts are IgM lambda, but polyclonal. The interfollicular plasma cells are IgM negative, and they are polytypic for light chains. Can I just quickly, can I go on to the next case? Then I will, yes. So this last case is a 64-year-old male, metastatic squamous cell carcinoma left neck. The primary is not known, and this is a tonsillar biopsy. So this tonsillar biopsy was a very fragmented tonsillar biopsy. This is not an excision biopsy, but chunks of the tonsil have been removed. And this, you can see there is squamous epithelium here and a sort of a fragmented bit of tonsil that has been provided. You can see there are some follicular structures here which look like reactive follicles of varying size, but something is going on in the interfollicular area. Here again, there are some, this is a large follicle and a not so large follicle with what look like there's reactive follicle centers with zonation. Here the dark zone you're seeing with prominence of centroblasts, and here on this side, which is cutting out here, is the light zone. So this is a reactive follicle center and a very narrow mantle zone, no marginal zone as such outside of this. Here another reactive follicle, here the follicle center here. And there's some fibrosis, but what is also striking is there seems to be some cellular infiltrate. When you look at it on high power, there seems to be a prominence of mature plasma cells amidst some lymphocytes. Here again, on the left-hand side, you're seeing the epithelium here. There is some reactive atypia, but this is benign, and some little bit of fibrosis. But what is important is that there is a cellular infiltrate here, which seem, even at this power, you can see that there are plasma cells. Here again, there's a little fibrosis, but there are plasma cells here. And on high power, the plasma cells are mature, and as opposed to what we saw on the infectious mononucleus, they're all mature plasma cells with a HOF and a small nucleus here. You can't really appreciate the clock phase chromatin, but you can see that they're maybe reactive, but they're definitely mature plasma cells. There are a few eosinophils as well. So what could the differential diagnosis be? So on the reactive front, when you see any parenchymal structure with some fibrosis, but a prominence of mature plasma cells, one would think of IgG4 related disease. So tonsillar biopsy is not the best place to make the diagnosis, and the criteria for diagnosing IgG4 related disease, there are a whole lot of criteria, and you should still think about it, and you can do the stains, but it could be something else that we haven't thought of. On the neoplastic front, extranodal marginal zone lymphoma, mucosa-associated lymphoid tissue, when it shows extreme plasmacytic differentiation, you might see you might want to enter that into your differential diagnosis. However, in extranodal marginal zone lymphoma, you will see a reactive follicle center, which may be partially colonized or whatever, and with the mantle zone, outer to the mantle zone, even when there's extreme plasmacytic differentiation, you do get you do get a rim of lymphoid cells, B cells, in forming a marginal zone. And also the plasma cell differentiation, so in other words, the extreme plasmacytic differentiation is related to the follicle in some way. Here, this seems to be, if I go back here, it's not really, it's just haphazardly distributed in the interfollicular compartment. This is not really related to this follicle in any way. So what about a plasmacytoma? Plasmacytoma is sort of a localized myeloma, essentially. There is generally in plasmacytomas, it's not often that you get just mature plasma cells. So you generally get morphological heterogeneity. You get mature plasma cells and you get the larger asynchronous forms. And so that is something that you don't really see here. And also it's mass forming. This looks very different. This is just like an interfollicular infiltrate with a plasma cell predominance. So CD20 highlights these follicular structures. There's a little spillage into the interfollicular compartment, but there is no marginal zone as such. The T cells are seen in the interfollicular area, and you can see on the CD138, it is forming these clusters and sheet-like, but remember, those were mature plasma cells. Also, I want to highlight that CD138 is a very good epithelial marker. So it's highlighting the squamous epithelium here. So the follicles themselves are reactive, CD10 positive BCL, 6 positive BCL, 2 negative germinal center B cells, and IgD is highlighting this mantle zone. So many of the plasma cells are IgG positive, but there's no increase in IgG4. So we can put that diagnosis to bed. Now, again, as I said, we have light chains. So from light chain stains, you can see that this is polytypic for light chains. So they are mature plasma cells, normal morphology. The CD138 is positive, and I also didn't show you that they were CD19 positive, negative for CD56 and cyclin D1. In other words, normal immunoprofile, but importantly, they are polytypic for light chains. So now we can exclude the neoplastic differentials here. So although it didn't look like a malt lymphoma with extreme plasmacytic differentiation of the morphology, you can see how important it is to correlate the morphology with the immunoprofile as well. The immunoprofile matches what we were expecting to find after seeing the morphology. So it has a normal plasma cell. So any low-grade B-cell lymphoma with extreme plasmacytic differentiation will have a normal plasma cell immunoprofile. In other words, they'll be CD19 positive and they will be negative for CD56 and cyclin D1. But you'd expect them to be monotypic for light chains. But plasmacytoma, on the other hand, they have an aberrant plasma cell immunoprofile. So they're CD19 negative. And they not always, but they may be positive for CD56 and or cyclin D1. But they will also be monotypic for light chains. So we can disregard all this. We have also excluded IgG4 related disease. So is there some other condition that we haven't thought about? And this is at this point, I would again, if I like to, I would have liked to have had a poll question to ask you what you think. But I'll give you the answer. And this is, we did a treponema stain. So this, if I tell you this history, if you go back to this patient had a metastatic squamous cell carcinoma of the left neck, okay? And they didn't know the primary. And they went looking for they were trying to look for the primary. So they did this tonsillar biopsy, okay? And now the head and neck pathologist brought this to me and said, I can't see any evidence of carcinoma here. And what are these? There's a lot of plasma cells. And I said, we said, I do the light chains, whatever. He had done everything. And I said, do a treponema stain. He said, really? Do you think really you need to do a treponema stain? I said, yes, please do. Because we have been seeing a surge of this recently. And here you can see the treponema pallidum is positive. Yeah. So treponema stain is positive. So this would be consistent with treponema pallidum. So this is a spirochete, this is a treponema specific antibody that is used for this, but you can also use silver impregnation stains like silver nitrate, but also Wathin stari. So this is really, you can see the spirochetes nicely highlighted on the treponema stain. And it was interesting, although we proved the diagnosis of syphilis, they still went back and did an excision biopsy of this tonsil because they were really thinking, in addition to the syphilis, could there be a carcinoma? And actually all there was this plasmacytic infiltrate and syphilis. So diagnosis is syphilis. Syphilis in the oral cavity. Yeah. So syphilis is a sexually transmitted disease caused by the spirochete bacterium Treponema pallidum. So there are 3 stages. They're primary, the incubation of around 90 days, secondary and tertiary syphilis. The primary syphilis may occur in the oral cavity. In this case, this is in the tonsil. Now, although not common, you should also consider it where you can see it in tongue biopsies, non-healing ulcers in the tongue, etc., or the oral cavity. And you should consider it particularly if there's a prominent plasmacytic infiltrate. It is really important to make this diagnosis because primary syphilis heals in around 6 weeks and leaves a scar. But if it's not treated within 8 weeks, it can progress to secondary syphilis. So I think it is important to consider this and not just think that, don't profile the patient, just look at what you see and then just exclude this, and it's so treatable, you see, this is the thing. So it's so important not to misdiagnose. So I'll end with this. Reactive lesions may show histological overlap with lymphoma, as we know. Obtain the clinical history as best as you can and request appropriate immunostains and interpret in context of the morphology and immunoarchitecture. Integrate the clinical imaging and histology with your immunohistochemistry. Yeah. And I hope there's no information overload, and I'll end with this.
Well, thank you very much, Ayoma, for that really good
I will stop sharing.
Talk and lecture. So, I mean, a small number of cases, but a huge amount of information. I mean, certainly infectious mononucleosis, I have been almost caught out in, maybe patients in their 20s between that and a lymphoma. And again, it's really come to light at the MDT discussion. And also the Kikuchi's and a high-grade T-cell lymphoma. So again, I've seen that as well, particularly with a small biopsy, limited material, large blasts, and again, yeah, we've even done the clinality, and it's skewed, but clinically it's only a small, usually a small lesion, localized, and systemically not unwell. So again, I've survived the trap, but I've almost fallen into it.
Yeah.
And I think that I'm not alone. So thanks for pointing that out. And I think that, like you say, the missing a lymphoma is bad, but treating someone who hasn't got a lymphoma is also bad.
Yeah. And sometimes you don't know which is worse, really.
Yeah.
The consequences of a young patient being young. We had an 18-year-old boy who was, the loss of fertility and so on. These are big issues. If I'm giving chemotherapy, we had one case patient over the Christmas period where the patient was brought in intubated, and the clinician had all the chemotherapy teed up because the diagnosis of lymphoma had been made, and it was just infectious mononucleosis.
Yeah. Yeah. And it can clinically, I'm sure
Because they're
colleagues.
acutely unwell, at
Yeah.
that point, they're acutely unwell. And he was, and they said, I said, tonsil enlargement. I said, my gosh, this is one thing. And then they had done some overnight testing for the EBV, which had been serology, which had come back negative, which was just, night testing, sometimes not accurate. The next morning they repeat the test. Yes, the IgM is high. It's all these things. I think you have to take the clinical into consideration. How often do you get, tonsillar enlargement and it's Hodgkin, or you know what I mean? It's just such an acute thing. It's really, and the age is the crucial thing, isn't it, Richard?
Yeah.
I mean,
Yeah.
really...
And it does literally blow up overnight. I mean, anecdotally, one of my children in his teens, literally, it was okay one day, and the next day I saw him and I thought, oh my God, he's got enormous nodes almost overnight. So we've got some questions in the Q&A. First one, you may have answered this already, but Castleman's, is it a reactive process or a lymphoma?
It's not a lymphoma. That's the first thing to say. It's not a lymphoma.
Yeah.
It should be treated as a benign condition. Whether it is what you call a reactive condition, although that is what I've brought it under, is a question which is difficult to answer. There are there's some evidence to say it's clonal, so then therefore it could be a benign tumor, but it's benign. And the treatment is excision, and the complication of FDC sarcoma is exceedingly rare. It does occur, we've seen it, but it is, once you take it out, that's it. So that is, I think, very important to recognize. It's not lymphoma. That is emphasizing that.
Okay. The second one, can plasmacytoma occur in nodes? I've seen them in bone marrows. Okay.
Yes, it can occur in nodes, but I wouldn't call it a plasmacytoma necessarily. I think it would probably be a disseminated myeloma.
Okay.
Yeah, but I think it's very unusual because it is, it would be, yes, it would be a disseminated myeloma, but not as a plasmacytoma. You see extramedullary plasmacytomas, but it would be very, very unusual. If you see that, I think you think of something else.
Yeah. And what immunoprofile would you suggest to distinguish infectious mononucleosis versus Hodgkin's, and try to think of as small a panel as possible?
So firstly, I would do a CD20.
Yeah.
And, if you do a CD20 and a CD79A, you will see that it's not just, together with your CD30, you will see that it's not just the CD30 positive individual cells that are there. There will be other cells as well. That is something that you see. You don't only see those individual cells. In Hodgkin, you don't really get any large B cells in the vicinity of these CD30 positive large cells. Yeah, what you see is CD30 positive large cells, either usually individually scattered, but sometimes you get the confluent sheets of them. But you wouldn't see them expressing B cell markers. So if you start seeing them expressing B cell markers, but more importantly, if you start from the morphology and you look at what I was trying to say, that you see these scattered cells, but you see a spectrum of plasmacytoid cells, mature plasma cells, and immunoblasts and Hodgkin. It's a spectrum of cells. You don't necessarily see you don't just see individually scattered cells. The reason you think of classic Hodgkin lymphoma is because you're looking at only the large cells, and somehow it's like rabbit getting caught in the headlights. You're not looking at the background. I mean, if you look at the background, you shouldn't make that mistake. And one of the issues you have is sometimes when there's a lot of necrosis, and you have CD30 positive cells in the vicinity and they're EBV positive, then you don't know whether to call it classic Hodgkin. But also just look at the distribution of disease and so on, I mean, those things are also important, I think. It's not just about doing an immunopanel and getting it. So and also if you do, I don't know whether you have access to EBA, because I know when I'm in Sri Lanka, I think it may be just coming in, because 2 years ago when I was speaking, they didn't have EBA. So I think worldwide EBA is not, in situ hybridization is not available. And, all you do is speak to the clinician and get an EBV IgM. And serology is available, Yeah, I mean, sometimes the problem is if the biopsy is small, and if your biopsy is small and it's not, I mean, you won't have a mediastinal biopsy where you're thinking of infectious mononucleosis. So it will be a peripheral node biopsy. And if you have a difficulty in diagnosis, ask for an excision biopsy. And by the time you ask for the excision biopsy, and by the time they tee up the excision biopsy, the patient will be a lot better.
Yeah. Okay. And then the worst is they've had an excision, and the best is that the excision's cancelled.
Exactly.
Yeah. Okay. Are there any other questions from anyone?
The question is answered. Do you want to ask that person if they want anything more?
Which person?
The person who asked me the question of the immunoprofile.
Oh yeah, sorry.
Have I answered the question?
Yeah, the person who asked about the immunos, is there anything you want added to that, please? Just let us know in the chat or the Q&A. And I think you can ask, you can put up your hand to be unmuted if you want to speak as well.
Yes.
And Ava can unmute any of the delegates. No. Okay, I think you've answered it very well, actually. We've got another one come in. Solve my question. Good. Thank you. That's great. Are there any more questions from the audience before we wrap up and let you get back to your day job? No, I think that's it. Thank you very much, Ayoma, as always. Sorry we only meet like this. We need to make sure we meet in some other forum as well. I'll be at the Pathological Society Winter School meeting. That's down in London, so hopefully see you there.
Yes.
Yeah. So without further ado, I'll say thank you to
Dr.
Attygalle. Thank you for everyone for your attendance and interesting questions, and look forward to seeing you all again next week. Or there's another thing popped up. Thank you. Okay, thank you. See you all same time as usual next week. It'll be myself. I do have a clash, but I will make sure that something is presented of educational value to you all. So keep spreading the word, everyone out there. Feel free to share the link, and let's build this growing community. So thank you very much.